I'm a walk-around guy, and I'm not a PowerPoint guy because I'm a social work guy, and social work is all about talking. But I did learn something in my time in the hospital that if I don't bring swag, you guys aren't listening. So here's my swag for later, but for right now, take what you want, pass it around, so you'll pay attention to what I'm saying, or at least you'll pay attention to something. So tell me, so I got the email to talk with you guys, and you're thinking, Mark Dale, a social worker, why is he talking to business class? Right? It doesn't quite, it's like apples and oranges kind of, except for social workers are they know a little bit of everything about everything, right? So spending my time in a hospital for 20 years-ish, almost, I had to learn the business of healthcare. Because if you're a patient sitting in a hospital room or a family member sitting in a hospital room and you're concerned about the cost or what's going to happen next for my loved one, if I'm going in there trying to help, I got to know what the business is of healthcare. So that's kind of how I know a little bit about healthcare and the business of healthcare. But I want to hear from you guys first for 2 seconds about what is this class? What are you guys learning in this class? So I know where we're going. Yeah. Okay. Kind of like a wine tasting party, right? You get a little bit of this, a little bit of that, a little bit of this, a little bit of that. That's great. I remember, so my history is I started at this campus myself in the way back. And so I started here and then went to the U and then went to Arizona State and finished up there. So I do have my heart bleeds Bruin blue way down there deep. So anyway, so let's talk about healthcare just for a second. Well, not a second, like 50 minutes. The first thing I want to talk about is a hospital, right? And so I don't have a PowerPoint, but we'll go with this. Tell me, what do you guys think of when you see a hospital or think of the word hospital? Grey's Anatomy, right? Cancer, okay. What else do you think of? Bills, indeed. What else? Hospital. Your grandma's going to the hospital. What's your thoughts? Oh no, right? Right? There's a lot of things that people think about when they think of the word hospital. And a hospital is all of that, right? It's usually, you don't see healthy people going to a hospital. Usually it's sick people going into a hospital or someone who needs something going into a hospital. When I have social work students in a hospital, we talk about how we can help the patients in there and what we can do to make sure that those patients are getting the services that they need. But one of the big things that students don't think about, and I think most people don't think about, that a hospital is still a business. That it still has to make money, and it still it has expenses, and it has payroll, and it has all those things that every other business has. And so sometimes we think of a hospital as this great organization, which it usually is, but you still have to do, work. There's still things to be done. So let's go in the way back and talk about hospitals in the beginning. So healthcare would start with hospitals. And when do you think the first mention of a hospital was ever made? 1751. Certainly there was hospitals then. Any other guesses? What do you think? 1900s? 1800s? Okay. What about the 5th century BC? What about that? Yeah. So if you think of hospitals back then, they certainly weren't called hospitals, but they were more like churches. Why do you think they were called? Why do you think churches was involved in taking care of sick people? Yeah. No, you're on the right track. Exactly. There was not doctors. There weren't people that could, diagnose and treat and so forth. So they relied on what they had at the time. They prayed. I won't want to say they tried to pray it away, but that was a place that churches were places of comfort. There was safety, and usually there were people willing to help. Because a lot of times when you think about society, a lot of times people are in what's in it for me, right? So, if the whole world is what's in it for me, you go to a church, you go to someplace that's willing to help, and that's how hospitals came to be. As far as the progression of hospitals is concerned, it's been an interesting swing. So when you were sick in the way back, 1700s, 1500s, where did you go to die? Where did you go to get treated? In your home, right? You were treated in your home because there wasn't a whole lot of hospitals. It wasn't a business. If it was churches, only the sickest of the sick are going to be in the churches. So it was harder to go into a hospital than it was to go to a church. Wait, does that make sense? It was, yeah. Anyway, so you died at home. You stayed at home. So the idea was that you were going to be at home more often. There was an evolution where that went from your home into a facility, into hospitals. As things progressed, as advances came along and people wanted to help, that's how you ended up making that progression. A little bit of trivia. The first hospital in the US was built in New York in the year 1743. Bellevue Hospital. It's still there today. Probably not the building from 1743, but the institution of Bellevue Hospital is that old. So hospital's been around a long, long time. The first pay hospital, and I use the word pay hospital because, again, if we go back to the idea of hospitals and helping and so forth like that, it was all charitable stuff. So the first pay hospital was built in London, and that was in 1842. Now, I know this isn't a history class, but I think it's important to give some perspective on where we came from as far as where we're going. Additionally, the hospitals, who's ever heard of like someone being on a ward, right? A hospital ward, right? What does that look like? Any ideas? Like a level? So in the way back again, you would have a room where you'd have a lot of people in that ward. So you've got 30 people sick in a room. Not really helpful for controlling your infections, but that's how things were, right? Wards were very popular and very economically sound, because if I'm a nurse and I'm trying to take care of people, if I got y'all in one room, then I can just go like that instead of individually going into rooms. It wasn't until the 60s that wards started to diminish, and they would do like 2-bed wards or semi-private rooms. So you'd have a semi-private room. St. Mark's Hospital, where I came from, was built in 1972. And in 1972, St. Mark's was the first hospital to have private rooms, right? Today, if you go to Intermountain, they've got rooms that are like the size of this area right here for one person, right? They're ginormous. And there's a couple different reasons for that. One of the reasons that that hospitals have gone to that is that consumers, you guys, have learned that you don't have to be locked into one thing, right? So the dichotomy has shifted a little bit. So instead of hospitals saying, haha, I got you, and you could only go where I tell you to go because of this insurance, now you have insurance that says, well, you have this whole network. And so hospitals, because it's a business, has to stay competitive. And they look at that and say, whoa, if you have a choice, am I going to go to a team, and not to crumb St. Mark's because I was there for a long time, but it's an older hospital in comparison now. Are you going to go to a room that's 300 square feet? Or are you going to go to a room that's 800 square feet, right? So you're going to go to a room that's a little bit bigger, a little bit nicer, because you want that experience. So that's a little bit of background with the hospital system. Okay, so we've talked about hospital a little bit. Now let's talk about payment. Oh yeah, you gotta keep passing the swag. And I'm sorry for those people who are online, you don't get the swag. Side note, no, I won't say that. We'll come back to the swag in a second. So payment, how do you pay for your health care? There's usually four ways that are right now that you can pay for your health care. Anyone know? You go to the hospital right now. How are you going to pay for it? Not to put you on the spot, but I'm putting you on the spot. Your insurance? Your insurance is going to pay for it, right? So the first way is insurance, but that insurance could be broken up into two things. Your own private insurance that you purchased yourself, or your employer insurance, right? So there's two insurance pieces right there. The third would be what, do you think? Straight out of your pocket, right? Cash. So I'm going to pay for cash. The fourth would be what? Insurance, cash. Anything else? Payment plan. That's okay. That's like cash. What did I hear? So payment plan. Okay. On the nose, right there. Government, right? So what are the two government entities that pays for healthcare? Any idea? You hear about this all the time. So if you're 65 or older, you get this. Medicare. Medicaid is what? So let's break that out just a little bit for a second, right? So Medicare is a federally based health insurance plan for those people who are 65 or older or who has a disability, right? And that disability could be a lot of different things, and we're not going to go into that, but a doctor has to essentially say, you are going to be disabled for either a year or the rest of your life, right? You have to meet that threshold first to get on Medicare, because the doctor's going to say you can't work ever, right? Because of this reason. Medicaid is a state-run program, and Medicaid is your state dollars, your Utah dollars, that pays for health care, and it pays for other things. So we're talking about health care right now, and that's a needs-based program. So a needs-based is like what we talked about. Someone was saying that you're financially unable to work. You might be a minor, not a coal miner, but under 18, or that you might have, again, a disability that doesn't allow you to work. So Medicaid is a needs-based insurance program. When did Medicare and Medicaid start? Any ideas? No. 1965. Dang. So 1965, Medicaid and Medicare was enacted when they were able to say, okay, we're going to allow for this kind of payment structure. In 1920, again, it's not history, but I think it's relevant. 1920, Social Security was enacted. Y'all know what Social Security is, right? And so at that time, they talked about enacting health care at that point as well. But that was shot down for many different reasons, mostly because insurance companies came on the scene. And as far as insurance companies have changed the way that hospitals are run and the way that you guys get healthcare. We all get healthcare. One of the first healthcare insurance company was called Blue Cross Blue Shield. You've heard of that, right? So in the way back, sorry I keep using that phrase, but it's way back there. Blue Cross Blue Shield was the insurance provider for the nation. They would insure people all the time for a lot of different things. And if any of you guys are in an insurance company, I'm sorry, I'm not crumbing on you. And I might have some of my history a little bit backed up or skewed a little bit. But Blue Cross was one of the first people to insure employees. It was important for employers to have healthy employees, right? Because if I'm an employer and you're working for me, I want you in my job. You know, you're supposed to be working. So if I give you health care, then you're going to work for me. So it's kind of an interesting relationship, right? It's not, you feel like it's, oh, they're caring for me. Really? Are you caring for me? I think you're caring about your bottom line. Again, I'm not crumbing on anybody. I'm just saying, if I'm an employer and I have employees, I want my employees to be healthy, to work for me, so I can make more money. So, Blue Cross was invented, and initially it did a great job. A little bit after that, like in 1929, the teachers union in Texas started to do a similar thing where they wanted their teachers to stay healthy, so they enacted their own insurance company. So there was a couple of fledgling insurance companies that started up, and so that moved the needle as far as healthcare is concerned. Tell me what happened in 2010 with healthcare. Anyone know? Affordable Care Act, right? Commonly known as Obamacare. What did the Affordable Care Act, what did that have to do with anything? What was the goal of that? Affordable care, right? It wasn't by an employer, was it? Nope. It was the government, right? Right. So if I go to the ER and I get treated and I don't have insurance, what happens? Who pays for it? Okay, so taxpayers pay, right? So I'll say, I'm sorry, I don't have any money. And so I walk out of the hospital, sweet, thanks, with treatment, but you're paying for it, right? It gets passed along. Everything gets passed along. Eventually you pay for it. And so the goal, among other things, was with Affordable Care Act, was trying to get the healthy people paying into the system so that we all have good health, right? Is that a good thing? I feel so. We got some things. So there's those people who are like, well, I'm healthy. I shouldn't have to pay into the system. I don't need to do that. And I get it that you don't want to pay for other people's processes, but eventually you are going to pay for it, right? In one way or another, you're going to pay for that health care. And we're not going to get into the healthcare debate too much in regards to insurance costs. But do you feel like we should have, well, I guess we are, universal healthcare? What is universal healthcare? You've heard that phrase, yeah. Out of the pool, right? We won't get there, is that what you just said? So as far as universal healthcare, what do you think some of the benefits would be? Okay. So affordability, coverage, any other benefits you think of having? What did you say? You catch the disease faster by having it? Oh, okay, all right. So if you are sick, then, I thought, what? So if you're sick, you're more likely to go to the doctor to get seen. Although if you're a guy, you're not going to go to the doctor anyway. So we know that. But anyway, that's a generalization, right? But you're going to go see the doctor sooner rather than later and hopefully get treated sooner. I hope. What are some of the drawbacks, do you think, of universal health care? Long wait time, a lot of red tape, probably in the wait time. Anything else? I'm sorry? Okay, it's quality. So that could be an issue because what's in it for me, right? If I'm a physician and I'm just getting this flat rate all the time, right? What's in it for me, right? Because that could happen. Right, right. There's a baseline, and we're not going anywhere. So there's no competition to increase that base. All right. Do we have universal health care right now in the U.S.? Tell me what Medicare is. Tell me what Medicaid is. You're right. That could happen. Let's say I'm 65. I'm on Medicare for life now. There I am. I'm on universal health care right now. Not now. Someday I will be. But if I'm 65 and I'm on Medicare, guess what? I'm already on universal health care. Yeah, you're right. Perfect example. Yeah, so if I'm on universal health care with Medicare, so you're the physician, I'm paying you to take care of the patient, and you need a specialist, so I send you over here, right? So then now you get a little bit of care, but it still bases on that universal model of just the one provider, right? That Medicare provider. Are we all on the same page? We got it? Makes sense? Good, good. Let's talk about this for 2 seconds. Profit versus nonprofit. You guys ever heard about that in healthcare? Okay. You're right. You're right. A lot of that. You are perfectly right. So the government, nonprofit. Schools, nonprofit. Hospitals, some are nonprofit. IHC, nonprofit. St. Mark's Hospital, for profit. So the difference is what? Yeah. No. It was a question. You go ahead. I like talking instead of. I like to hear your guys talk.
Well, profit for hospitals, they want to make money for their property and.
You're on the right track. You got it.
And like income tax.
Okay. They have to pay income taxes. You bet.
So they charge people for everything. And then you got the nonprofit, are usually, like he said, where they're kind of like by the government, so they just answer shareholders.
Okay. Okay. Yeah. Yeah. I like that. For profit is exactly what it sounds like, right? We're in it to make money. It's not a bad thing. It's not a good thing. It's just that's the driving force right now. Is we got shareholders. We need to make money, and with that money, we will do good things. But the end result is we want to make money for this, right? Nonprofit, you have to make money too. You have to continue moving forward, but it's not the end result. The end result is not to IHC, right? They're humongous, right? They're humongous. They make money, and they build great clinics and they build a lot of things, but they're in it for, like you said, a healthier environment, right? They don't have to pay taxes because they're a nonprofit status, but they're in it to try and help the community, the greater good in that situation. So a lot of people have felt like for-profit and not-for-profit is an evil thing in healthcare. I don't think it's either, personally. I think you can help people when you're making a money. When you're making a money, you're making a money. You can help people when you make money, or you can help people if you're putting it back into the community or into your environment, right? So I've heard there was a lot of pushback that I would get in different situations when they'd say, oh, you work for St. Mark's, it's a for-profit hospital. Yeah, it is a for-profit hospital, But we still do great care. We still do all these things. We still help people. Our goal is to make sure that patients healthy, but we're making money, and as not we, I didn't make any money there, but I made some money. But as a company, they are making money and going forward. Any questions on that so far? It's pretty easy, straightforward. Yeah. Great question. And we're going to get into price in just a second. Well, actually, let's just go there right now. I think let's just go to cost right now. So, cost in a healthcare. Just recently, there was some legislation passed where hospitals have to say how much a gallbladder surgery is going to be. You heard about that a little bit? So if I'm going to get my total knee done, I can go at the University of Utah and see what it's going to cost me to get my total knee done. And I can go to Intermountain, I can see what it costs, right? So there was legislation that was passed that said you need to post what that cost is. And to me, and again, this is gospel according to Mark, it's very nebulous, meaning it's kind of a wishy-washy answer, because the way hospitals work is that they will contract with a provider, like an insurance provider, and say, okay, Mr. Blue Cross Blue Shield, we'll go into an agreement with each other. And so that agreement says that if you bill us, or let's say I'm the hospital there, so I'm going to bill you for a total knee, and that was $50,000. Well, I've got an agreement with you, the insurance company, we're going to call you Blue Cross, that if you bill me for $50,000, we have a lump sum that says anything between $60,000 and $40,000, I'm just going to give you $35,000. So it's kind of a weird relationship, and that's why the prices are so hard to understand, is because there's not, like, you can't go to the grocery store and say, I'm getting paid, or I'm going to pay $5.99 for this item. It's a contractual agreement with the insurance company. So if you come in for a $30,000 knee, if you paid cash, you're going to have to pay that $30,000. But if it's an insurance company and I give the insurance company that $30,000 bill, they're going to say, thanks. And you've probably seen this on your insurance bills, right? Or your statements, where it says your visit cost, $75. Your insurance company paid $14, something like that, right? You've seen that. So there's a contract agreement set up with your insurance company that says you could bill $1 million, but we're still just going to give you $14 or whatever, right? So that's why it's so hard to say for-profit versus non-profit as far as how much it costs, because it's really hard to say. And I will say this: there was someone on the news talking about that the other day, saying, "Well, now I know that I'm going to go to this hospital for this because it's cheaper." To that, I would say, you don't know what you're getting with that, right? Your physician, yep, they're a physician, but what is their infection rate? What's their success rate? Those types of questions you don't know. And if just to put a blank number on it, $5.99, well, I don't know. I mean, that can be hard if you're just paying that $5.99, because I might get in a slouch doctor or a great doctor. I don't know. So, yeah, it's a hard one to come up with. Also, since we're talking about cost, and this goes back to the for-profit, nonprofit, and payment system. So again, if I go back to the piece where I can't pay my bill, I've got bad debt. So now I'm a hospital, and I've got this $20,000 debt right here in my hand. What do I do with that debt? I go after you to pay for it, and you say, can't do it. Can't do it. Don't know how. Don't have that money. So now I'm stuck with that debt. What does that hospital do with that debt? They sell it, right? And that could be good and bad. It depends. So if you've got a $20,000 debt, I'm a hospital, I'm going to sell it for pennies on the dollar to some collector to try and get the money out of you. So he's going to try and get that $20,000. You're going to say, I can't do it. And he's going to work and bug and try and get the money out of you for that reason. And that could be hard. And there's been legislation about how much debt collectors can go after you. But that's how hospitals survive and how they pass it along to all of us, right? Hospitals have changed from when you first went into the hospital, 50 years ago, and you would be there for a long time. Insurance company would pay just a flat rate or just pay as you go. So for every aspirin, it's this much money. For every treatment, it's that much money. And it's like a grocery tab. Chink, 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 chink. Just keeps adding up. Insurance companies didn't like that after a while because it just costs a lot of money, right? They're just paying a lot of money. So then they came up with a bundled payment, right? So for that total knee, we're going to take the average of what that total knee costs, $15,000, and we're going to pay you that $15,000. And if you're the hospital and it costs you $20,000 to get it fixed for whatever reason, so say you got an infection and you stayed in the hospital longer, you're still only getting that $15,000. So that was the model that we're currently in right now, is the bundled payment system. So they're just getting, every hospital system is getting a lump sum amount of money for the treatment that's going into it. So if it costs a little bit longer or takes a little longer, then that's why, hospitals try and get you out sooner, right? They play the averages. So if I can get you out in a day instead of 3 days, guess what? Then those 2 days, they come to my pocket. So that's where we're at right now with our system. But Medicare, we're going back to Medicare. Medicare is a driving force in healthcare. And the reason that is because the majority of people who go to the hospital are older people, right? Most of you guys probably have never been in a hospital or need to go into a hospital, hopefully, because you're healthy. Your bodies haven't worn out, right? Your parts are still good. But as you get older, your parts break, your parts wear out, things happen, right? So Medicare is the driving force as far as pushing the standard out there to the healthcare. So Medicare is saying, what we're going to do now is look at value-based performance. So we're going to say, how well did you take care of this patient? And how well did you move them across the continuum? That continuum starts at the hospital. And let's say you need to go to rehab. And then from rehab, you need to go to home health. And then you go to a clinic, right? So now I've got all these steps in between along your continuum of care, starting at the hospital. And so that money gets now spread between all of those providers. So if you're all those providers, you form a little pact. They call it ACO, Affordable Care Organization. So you and your group, you all work together to try and make sure that your patients are well taken care of in the shortest amount of time or the least restrictive. So as you can imagine, this is the highest part, is the least is clinic. So you're trying to make them be in this bucket instead of this bucket as an affordable care organization. So you're trying to manage their care the best they can. So that's what you're trying to do as an affordable care organization. That's where we're going. And that's all well and good. But the hard part is this. If I'm a physician, I bill separately. I don't bill with these guys. You've seen that in your hospital bills or so forth, right? So these guys bill you, and then here's my bill. Well, that sucks. Because it's not going to change, and this is, again, Mark's doctrine, not anybody else's. Things are not going to change until it affects the doctor. So once the doctor gets hit financially because of whatever kind of care is going on here, that's when things change, is when it hits the physician. And I understand that physicians, they have to treat. They should not be focused on the money. I don't want a doctor focused on money. If they're looking at me and they're saying, Mark, should we do the cancer treatment or not? Well, do you have money or not? I don't want that. I just want it done, right? So that's the hard rub that we've got going on here. Is that you've got physicians who don't want to be controlled by insurance companies, but then you've got insurance companies saying, well, we're going to control you because this is how much money we give you. So where does that lead us to the future? Who's heard of the silver tsunami? Never heard that? Well, let me be the first to tell you. The silver tsunami, what that refers to is the baby boomer generation getting older. So by 2015, I put one statistic down here because I thought it was interesting. By 2050, 20% of the American population will be over 65. That doesn't seem like a lot, right? 20%? That's a lot. That's a lot, 20%. Of how many people are in the US? 300 million-ish and change? That's a lot. That's a lot of folks. And as we talked just for a minute, that as you get older, you need more services because your parts are breaking and wearing out. So in just 25, 30 years from now, you're going to have a lot of needs for people who are of the baby boom generation, a little bit over, right? So one of the benefits of looking forward or looking to the future is you need to take care of these people. You need to take care of as far as health or as far as business, a business class and looking to the future. You have an unlimited supply of business, right? Because there's always going to be more people. People are always going to get sicker and things like that. So the silver tsunami, which is coming, and we're just starting to see a little bit of an uptick, will come, and we're going to go, holy mackerel! Now we need more providers to care for these people. I don't know if you noticed as you drive around. You probably don't because you're not in healthcare. Have you ever seen all those assisted living buildings? Right? They look like apartments, but there's a ton of them. And that's because as people get older, they can't stay at their home any longer. They don't want to go to some skanky nursing home. They want to be in a nice apartment setting that provides some care. And so that's where this is all moving, is trying to move towards to taking care in a home-like environment. A couple of years ago, I was at a conference and the speaker was talking about, as this silver tsunami moves forward, that hospitals will have less and less patients in their hospital, and more people will be cared for in their home. Hospitals will have less patients in their home, or hospitals have less patients in their hospital than treating in their home. Which is kind of funny if you think of, go back here to the hospital history, people went from their home to the hospital for care, and now we're going from the hospital back to home for care, right? So what does home care look like? Well, it's not surgery. You can't do surgery like you do in a hospital. You can't do a lot of things, but you can do a lot of things in the home. A lot of physicians are now being able to go into the patient's home. You've all seen the commercials of, talking to someone on an iPad, right? So a lot of physicians are making that transition on how can we provide care to you in your environment. But we could, a physician can in the home prescribe medications, can do simple things. They could actually have a home care agency come into the home, draw blood for a test, and see what's going on with that. And then from that, prescribe medicines to you. X-rays, you can do that at home too. When you think about that cost, it all boils down to how can we share the cost amongst these people. Remember that, my train of people, hospital, home care, or rehab, home care, home. So if I share it with the lower cost people, guess what? We make money. And again, I'm not saying that it's bad to make money, but you have to make money to survive in your business. So you can, that whole continuum of care, you can start from the hospital and then go all the way to hospice at home. You know what hospice is? Everyone heard of that? Hospice is end of life care, where you would be treated by a physician. They're not hastening death, they're not speeding it up, but they're providing care to patients at the end of their life. They're not doing any curative care at all. They're doing just what can we do to make your life better, with the time that you have, usually with some sort of terminal illness of sorts. What do we got? We got 4 minutes? 4 minutes. Okay, any questions so far? Let's see, because I've got my trivia that I've got for my swag right here that I need to give out too. So, just for a second, let's talk about ethical issues that come up with healthcare. What do you think some ethical issues when we're talking about healthcare? How much is a life worth? Loaded question though, right? Money, right? We're talking about money. So for-profit versus non-profit right there. So I'm a pharmaceutical company, up the rates on your insulin so I can make money. Okay? So that is an interesting question. How much is a life worth? Ever heard that question before? It's a scary question. An insurance company would say, and this is from a study about 10 years ago, an insurance company would say, well, your life is worth $50,000 if I can provide quality of care for a year. Does that make sense? So we're willing to dole out money on you if this investment that we gave to you provides you quality of care for a year, quality of care in life. That's gone up. It's more like $130,000 right now. But that's a sad, sad thing. The insurance companies are saying, yeah, you're worth, and again, this is generalization. Everyone has their own different ideas of so forth, but insurance companies say it's about $130,000 right now for a year, and that's a scary thing. So there's a lot of things we don't even think about. When you're sick, when you're in the hospital, when you've got pancreatitis, you're like, oh, I'm just dying. You don't think about that. If you got cancer, I don't want to. My life is worth more than $130,000. Maybe. It's kind of scary. Okay, any questions?